We have as speakers today Dr. Gabriel Chamie, who is an associate professor of medicine and infectious diseases epidemiologist with a very impressive trajectory through Yale, Stanford, UCSF, Berkeley, has done a lot of work on HIV and tuberculosis in Africa, and his clinical practice is at the San Francisco General Hospital. Dr. Carina Marquez is an assistant professor of medicine here at UCSF as well, also an infectious disease epidemiologist with training at Harvard, UCSF, and Berkeley. She has done work on tuberculosis and also on the disproportionate impact that COVID-19 has had on Latinx population. Her clinical practice is also at the San Francisco General Hospital. So without further ado, let me turn the floor first to Dr. Gabriel Chamie. Gabriel, you have the floor.
Thank you very much, Dr. Sepulveda, and thank you all for the opportunity to present today on our topic, SARS-CoV-2 community transmission during shelter-in-place in San Francisco and the Unidos Salud Testtocare model. Carina and I have no conflicts of interest to report. And I just also want to take a moment to explain how we're going to present this as a shared presentation. For part one, I'm going to discuss an initial community-wide testing effort that took place in late April 2020. And for part two, Dr. Marquez will take some time to discuss a low barrier surveillance and testing effort at 24th and Mission at the BART and Uni Hub there. And then for part three, we will spend some time discussing the response. Dr. Marquez will lead that discussion, and then we're wide open for questions and look forward to discussing with you. I also just want to say that we're presenting these data on behalf of a large research team, the Unidos Salud research team that's made up of many different partners and experts and community members, and we will be thanking them on our acknowledgement slide as we get there. But as a brief note too, there were many volunteers, including volunteers from UCSF, who took place in this. So thank them all in advance. Next slide, please. Okay, so we know that hospitalizations and deaths represent a small fraction of the total SARS-CoV-2 infections in a community. However, the burden of community SARS-CoV-2 infections has been difficult to ascertain due to a focus, especially initially, on symptomatic people and lack of accessible testing for most heavily affected communities, a problem that has resurfaced this past summer with a recurrent surge in the United States. Communities of color have been disproportionately affected by COVID-19 across the US. In California, more than half of COVID-19 cases are among Latinx people, who make up 39% of the state's population. Sorry, I think our slides may have some timing on them, so we'll work to keep on them there. As a result, there is an urgent need to understand the dynamics and the risk factors as this pandemic evolves that are driving ongoing transmission, both during and shelter in place, and as communities ease and change restrictions over time. Next slide, please. So the Unidos on San Francisco study, or United in Health, the objective is to characterize community SARS-CoV-2 transmission in this first study that I'm going to present in a densely populated majority Latinx US census tract during San Francisco's shelter-in-place mandate in April 2020. Our intervention was mass low-barrier SARS-CoV-2 RT-PCR and antibody, we used the Abbott Architect IgG test, for all community members, regardless of symptoms, at large outdoor community mobilized events or health fairs, conducted in partnership with the Latino Task Force for COVID-19 over 4 days. So the goal here was a rapid mass testing push at this time. The eligibility for testing was census tract residents who were 4 years of age and up, as well as non-resident workers. Next slide, please. The setting where we tested was in the Mission District from April 25th to 28th. And this might seem like eons ago, but this was 6 weeks into shelter in place. And this census tract is in the Mission. It's the second most dense population tract in San Francisco. of all census districts that have more than 5,000 people. And it is the highest with a significant Latinx population. It's Census Tract 22901, which is in the southern end of the mission, and has 4,087 adults over 20, 58% Latinx, and 34% with a household income less than 50,000, and roughly a quarter with a household income greater than 100,000. So quite a diverse neighborhood and a microcosm in many ways of San Francisco. Next slide, please. So the study outcomes that we'll be discussing today from this April study was the first understanding the burden of SARS-CoV-2 infection at a community level at this point in time, 6 weeks into shelter in place. And we looked both at the point prevalence of active infection, meaning PCR positivity, regardless of symptoms, as well as the cumulative incidence of SARS-CoV-2, which was a aggregate of being PCR positive or antibody positive at the time of testing. We also were interested in understanding the evolution of infection during shelter in place by comparing those who were recently infected, that we defined as those who were PCR positive but did not have antibody production, so the antibody negative, PCR positive, compared to those with evidence of prior infection, meaning that they were no longer PCR positive or PCR negative, but they were antibody positive. We sought to characterize asymptomatic cases and understand the phylogenetics of virus identified to measure strain diversity in this community. Next slide, please. I'll just take a moment to say that, at this point in time in April, there were really, as we were planning it, it was just several weeks into shelter in place. And there were some big, just logistic questions. I bring this up given our audience and the work that many of you do. But the questions that were raised were, first and foremost, is widespread community-based testing even possible? First, there were barriers to consider in terms of community event logistics during shutdown and during the public health mandates of sheltering in place. There's a concern that there'd be no place to do testing. There'd be no people to do the testing or volunteers willing to put themselves at risk, and no protocols to handle sick patients at this time. Of course, many of these things have evolved, but in terms of community perceptions, there was concern that people might be unwilling to test if they're asymptomatic. People might be unwilling to leave their house given the shelter-in-place order. And I think a persistent concern is testing safe. Who are you giving my information to? If you collect my information, will that be shared with the government, with companies, with immigration agents, et cetera? And then in terms of lab and technology, during heightened periods of testing, and there was a concern of no lab supplies available to do the testing, no labs able to perform testing at this scale for research, and no systems to get data and results rapidly back to participants. Next slide, please. So what we did to overcome these barriers, and I won't go into a huge amount of depth, but I'll say really the key here was partnership, both with the community, led by a collection, the Latino COVID-19 Task Force in San Francisco, which is really a collection of CBOs that have come together under incredible leadership and energy to address COVID-19 for the Latinx population in San Francisco. And also, and they played a key role really in mobilization, as well as guiding our response, as well as Supervisor Hillary Ronan's office, the supervisor for the area that we were working, the Office of Mayor Breed, the San Francisco Department of Public Health. We worked with San Francisco Recreation and Parks to use 2 parks for testing sites, as well as San Francisco School Board for 2 schools. Shown here is the Flynn Elementary School. Right across the street, across Cesar Chavez from, and it was a testing site for this study, as well as, of course, UCSF, San Francisco General Hospital, the CZ BioHub, and the UCSF Clinical Lab. And importantly, we recruited and trained 450 medical and community volunteers to make this possible. Next slide, please. In terms of community-led mobilization, I think this is worth mentioning both as important then and important now, which is that at the time, there was a lot of questions about COVID, a lot of unknowns, and a lot of misinformation, something that has persisted, as well as fears. And so the goal here was to provide trusted information from community members. There's canvassers with our volunteer headquarters at the Mission's Brava Theater, who visited households ahead of and during the testing campaign to get the word out and provide reassurances about what services were offered and that the testing was legitimate. Community groups and media organizations offered radio and TV airtime, as well as printed news coverage to the testing effort, including in local news such as Michigan Local. Next slide, please. And as I mentioned, we had a big team from both UCSF, the CZ BioHub, Berkeley, and with the support of the DPH as well. Next slide, please. All right, so who did we reach for COVID-19 testing over these 4 days? In total, we tested 3,953 community members. The total number of residents from the census tract was 2,653. There was 460 people who did not live in the census tract but worked within that census tract. And then given the high demand for testing we were observing, on the last day of the 4 days of testing, we allowed people in adjacent city blocks, roughly a 2 city block radius around the census tract to come, and 840 came on that day. In terms of the adult census tract residents, we had a population denominator from 2018, and 60% of adult census tract residents were covered by our testing effort. 53% were male, 47% female. And here's the distribution of ethnicities, people who tested by identity. 40% identified as Latinx, 41% as white, 9% is Asian, 2% is Black, and 7% is other ethnicities. Next slide, please. When we look at the point prevalence of SARS-CoV-2 by PCR positivity, in the community total, which is a mix of the residents and workers, we saw 2.3% PCR positivity. But as you can see, there's quite a big difference between those who worked in the census tract at 6.0% PCR prevalence versus 1.7% for those who were tract residents. And for the adjacent city block residents, this was similar to the tract residents at 1.6% positive. Among the PCR positives, 95% identified as Latinx and 3/4 as male. And PCR positivity was 20-fold higher among Latinx compared to non-Latinx residents, with the prevalence shown there. When we look at risk factors for PCR positivity, they're listed here, and I'm going to provide a reference for this work because this has now been published. But male sex at birth and Latinx ethnicity. Sorry, back one slide, please. And occupation type. So frontline service work and unemployed status were significant risk factors compared to non-frontline service jobs, as well as annual household income less than $50,000 per year compared to those making greater than $100,000 per year. And key to this, of course, is those who are unable to shelter in place and maintain their income. 93% were PCR positive compared to 55% unable to shelter in place and maintain their income among the PCR negatives. Next slide, please. So what percent of people had any evidence of infection? Well, this is our cumulative incidence metric, looking at a mixture of those with evidence of prior viral infection or evidence of current viral infection by antibody or PCR. And our total absolute number tested positive by PCR or antibody was 4.6%, with breakdown by ethnic group as shown here. And the estimated cumulative incidence among tract residents, so this is focused on those who live in the census tract, was 6.1% at this point in April. And this is after adjusting for the characteristics of the antibody and the PCR tests, as well as adjusting for who did or did not participate based on 2018 census data of underlying resident demographics. Next slide, please. Okay, so as I mentioned, we wanted to also compare how did prior versus recent SARS-CoV-2 infections compare in order to try to get a better understanding of the shelter in place may have shifted the dynamics of ongoing transmission. And among all infections, 53% were prior infections compared to 26% recent infections. I apologize, I'm presenting from my office at San Francisco General Hospital, so you may hear some ambulance noise. But if we look at the differences then in prior infection, which in each of these categories is the top bar graph. This is PCR negative, antibody positive for race and ethnicity, employment type, and household income. You can see that prior infections occurred across a greater diversity of ethnic groups, employment types, and household incomes, whereas recent infections, the bottom bar here, became increasingly concentrated among low-income Latinx frontline workers during shelter in place. Next slide, please. Okay, so importantly, more than half of PCR positive people were asymptomatic at the time of testing. Also, just to give a sense of severity of infection, of the 83 people identified with PCR positivity, only one required hospitalization, again showing perhaps a large proportion of those identified had mild or even or asymptomatic disease or infection. And what is shown here is differences in levels of virus. These are measured by cycle threshold. So the higher the cycle threshold, the lower the level of virus. And as you can see here, we saw no significant difference in levels of virus in asymptomatic versus symptomatic people who were PCR positive and antibody negative, meaning recently infected. Those who were PCR positive and antibody positive, whether symptomatic or asymptomatic, suggestive of more distant infections, had lower levels of virus consistent with resolving infection. Next slide. When we look at the phylogenetics of the SARS-CoV-2 infections identified, we see that SARS-CoV-2 genomes were recovered from 59% of the PCR positive samples, and 5 phylogenetic lineages were detected, shown here in panel A, that are intermixed with samples across San Francisco. And in panel B, you can see that at the household level, we did see clustering suggestive of intra-household transmission. Next slide, please. So in summary, the estimated point prevalence of PCR positivity among Latinx residents was 20 times that of non-Latinx residents 6 weeks into shelter in place. This is a trend we're seeing continue to this day. The estimated cumulative incidence among residents in the census tract was 6.1%. During shelter in place, we saw that recent infections became concentrated almost exclusively among low-income Latinx people who were unable to work from home and maintain their income, suggesting acquisition, I think, while either trying to trying to look for work or while working. And the majority of PCR positive infections were asymptomatic at the time of testing, and recent infections had high levels of virus regardless of symptoms. This suggests that testing limited to symptomatic people will fail to limit transmission. We saw high sequence diversity of SARS-CoV-2 infections, suggestive of multiple introductions over time acquired from across the city. And for those interested in more details, these data have now been published in Clinical Infectious Diseases by Carina and myself and our team, shown here is the reference. And I'll turn it over to Carina now to present. Thank you.
Okay, thanks so much, Gabe. Okay, so in part 2, I'm going to talk a little bit more about some of the other initiatives and things that really grew out of that first study in April. And so I'm going to talk first about our low barrier testing projects at transport hubs. So the transport hub study, we had 4 main goals. And I think it was really built on this idea that we knew from April that low barrier community-led testing worked, but we wanted to expand it a little bit further and think a little bit more about location and see how that played into it. So the transport hub study was to test the acceptability and feasibility of a low barrier transportation hub-based testing program. And then we also added a built-in fast track program for workers in the mission and public transport employees. And I'll touch on that fast track program in a little bit. The second test objective was to look at the yield and risk factors for PCR positives, and then also to evaluate our test to community care model, which we used in April, and we wanted to continue to evaluate it in the second study, and I'll tell you also a little bit more about that. And then we also wanted to look at the COVID-19 viral strains from a transport hub and look at if there were same strains or new ones coming into San Francisco. So a little bit of context. So the transport hub study happened last month, and so this just gives you a sense of the trends in San Francisco and San Mateo. And so we're now at that time at 9,349 cases. So this gives us a sense of where we were with the mission study. And then at the second peak, we did the transport hub study. And this also gives you, we did reach some people in San Mateo who were coming to the BART transport hub station, and so it gives you a sense of what was happening in San Mateo, which is neighboring to San Francisco. So the transport hub study, this is a picture of the 24th BART station, and we offered in August for 3 weeks, twice weekly testing in the morning and afternoon. And we just set up right at BART Plaza. We had bilingual staff. We had community-led mobilization with the Latino task force. And then one of the features that we offered, we knew from the April study that frontline workers were very heavily affected by the epidemic. So we wanted to make sure we were able to reach this population. And so the Latino task force, prior to setting up, prior to the testing, went to local businesses, and they were, trusted community members, went to local businesses, discussed the study, and then handed out fast track cards. And so these were cards that basically were VIP cards, and people could take them and then cut the line and get rapid testing, get in at lunch break, do their test, and then go back to work. And then we also offered fast track VIP, we call them care cards, to people who were household contacts of people who tested positive in this study. So in addition to being in a pretty convenient location, we also had these fast track cards. We also, for everybody who was PCR positive, we offered our Test to Community Care Services, which is a community team that provides supportive services for people who test positive, which I'll discuss. And again, this really was possible through the partnership with the Community Latino Task Force, new partnership with BART and SFMTA, and then ongoing partnerships with the Department of Public Health and Supervisor Ronan. This is just a picture of the care card for household members, and the community wellness team, which I'll get into a little bit more, when they dropped off food and cleaning supplies, we also dropped off these tickets for people to give to their household members. And then we also recognize that there's a possibility that they may have contacts that they may not be comfortable disclosing to the Department of Public Health, and so they were also able to give these cards out to them as well, that they could take and cut the line and come back for testing. So if you were tested on a Monday and you tested positive, your neighbors or contacts could be tested on the Wednesday. So these are just sort of early preliminary data. So again, we were looking at acceptability, feasibility, and the yield. And so we certainly found that this was highly acceptable. We tested 2,622 persons. It was feasible, it was high throughput. We were testing about 100 people per hour, and this was made possible by very simple, people just got in line, they answered a quick questionnaire, and then did their test and went. And it was certainly quite high yield. So of our the people tested, 9% of people were PCR positive. And this is compared to a test positivity rate, for example, in testing centers in the Embarcadero of 1%. So it was certainly, we certainly knew we were reaching a high risk population. So things, as I mentioned, that made, I think, this testing successful were the location. It was right, it's right, the transport hub is right in the center of things. You're catching people going on and off buses, people going to businesses on 24th Street. The ambiance was nice. We had welcoming Spanish, bilingual speaking people doing the intakes and community members. No need for appointment, you can just walk up, no need for ID, and had pretty convenient testing hours. I think in some of the barriers at the testing site that we've identified is just first day we did 500 tests by 1 or 2 o'clock, and so we had to close early. So I think some sort of changes in the testing hours presented some challenges. And then sometimes people exiting transit were a little bit too busy for testing at that time, but we hope they came back. So this is certainly a different sample population than the April testing study that Gabe talked about. It's a convenient sample. Anybody could really test and walk up. And this gives you a sense of the location reach. So the majority of people who tested lived in San Francisco. And so you can see over here, this is just sort of a graph of where people live who were tested. And you can see people all the way out in Antioch, Solano County. We had a lot of testers from San Mateo County and Daly City. And then you can see over on this side, the PCR positivity rate by within the city. Again, you can look at the heat map, and as expected, the PCR positivity was higher in the southeast sector, which is similar to what we're seeing in the city. I think the other interesting point is that this transport hub really does, even though it's in the mission, reaches a lot of people outside of the mission because people are coming for work and for other activities. I think there were a few people that came specifically for the testing, but it's a very central, easily accessible place. So let me just tell you a little bit about the details of the people who were PCR positive. I don't think I had it in the last slide, but the majority of testers were Latinx, and the majority of PCR positive persons were also Latinx, 93%. 85% of people who tested positive were, preferred Spanish as their language. And when you just stratify by race ethnicity, 11% among the Latinx testers, 11% were PCR positive compared to 9% overall. And then people, we had I think compared to the mission study, which was just sort of was that community-based sample, the majority of people, we had a lot of people coming to that had some symptoms, and for those people with at least one symptom, 25% of those people were PCR positive. The majority of people who were positive were low income at 87%, and 79% met criteria for what we called high household density, which there was a median of 6 persons in the household. Of those people, of the positives, only 22% had 6 leave coverage. And then another thing that was interesting to quantify is that we also did get a number of testers who had prior positivity but were testing because they were told by their employer they needed a negative test to return. And some of them were weeks out of positivity or out of their initial onset of symptoms. So let me just turn to, I think, another important goal and something that we're really focusing on, which is the operational cascade for symptom to isolation, specifically for vulnerable populations. Oftentimes when we were making these calls, and I think this is, it's not just exclusive to us, but by the time we reached some of the people, they would say, oh, well, my symptoms were 10 days ago and or 12 days ago, and they were already out of that period of isolation. And so it kept thinking, we're kind of reaching some people a little bit too late. And so I think it's important to really focus and hone in on how we're doing with this cascade. This graph just highlights sort of what we're calling sort of your infectiousness, or your sort of the viral load, and it kind of peaks and then goes down, and you're infectious for 10 days. And we really want to catch you early and be able to get and support people to isolate early and maximize the time where they're not infectious and at work, et cetera. So this is what we're saying is the operational care cascade. And we really want to we want to make sure we have the maximum amount of isolation during this time period. But that's a little bit hard if access to testing is hard, or it takes a long time for test results to come back. And certainly at our site, I think we really achieved sort of low barrier testing. Access was easy, but we aren't there all the time. We just showed up. And so this is, and then there still is time. We try to maximize the time our tests return, but there's still a few days. So this just gives an example of the operational care cascade, the time from symptom onset to isolation, and on average it was 5 days. And we'd love to be able to shrink this. There are some people that you can see that the time from symptom to isolation was up to, 21%, so 1/5 of people, it took 8 to 9 days from their time of symptom onset to get their positive test. So that was about 66% of people. So let's delve into this a little bit more. Where are the delays, and really how can we address them? So getting tested. So 66% of people tested 4 days or more after the start of their symptoms. And we asked people sort of what what was, tell us a little bit more about that. And I think what the most common thing that we heard was just talking about access, that they weren't feeling that sick, and it was hard to get a test, or there were not enough appointments, and so there were still barriers to accessing testing at that time. And then I think there was some people thought maybe their symptoms weren't COVID, and we're actually, I think, seeing this. We've had a lot of reports of people thinking they had sore throat because of the smoke, but it really ends up being COVID. So I think there's other ways to intervene. So intervening in terms of access and education, I think are two ways to shorten that cascade. And then, of course, faster test turnaround will also help. And so in terms of our cascade, getting results to persons, we were able to do that within 48 hours, and we'd love to continue to do better and optimize this cascade. So that is the mission with our next one of the missions with our next transport hub study. So we yesterday launched the testing transport hub study at 16th and Mission BART, and this is a picture of it from yesterday, and some of the flyers, and we're really focusing on reducing that time from symptom to isolation, and would love to report data back once we get it. So that's testing, and that's a big piece of addressing the epidemic. But another really important piece is the response. We don't want to just test and not have a coordinated response to help support people to get through isolation. So this moves us to part 3, the response part. And these are just pictures of our community response team, our community wellness team, which I alluded to a little bit throughout the talk. So as I mentioned, we need a coordinated response. We're seeing that socioeconomically vulnerable communities are disproportionately affected. In San Francisco, predominantly Latinos. And so to test, we also have to be able to support, because isolation, as we all know, is extremely difficult, especially if you are the sole breadwinner for your family, and not being able to go to work can be financially catastrophic. And if you don't have unemployment or sick leave, it is so devastating. So we need to make sure that we as a community, as a study, of course, but also I think in larger picture, are there to be able to provide the services that are needed. The DPH does, already has a lot of fantastic services, and so when they call and do case investigation, there's services for food and cleaning supplies, but we also then build off that and really added sort of augmented support and longitudinal support that is specifically tailored to address needs of socioeconomically vulnerable communities, to add on to the services that already exist. So this is what we call the test to community care model, and really providing wraparound services for COVID-19 positive individuals. And so this is kind of illustrates the sequence of events. So results get disclosed. DPH case investigation and contact tracing services proceed as they usually proceed, and those services are provided. And then we had our test to community care, community wellness team, then also provide augmented longitudinal support services that included daily, regular check-in calls, wellness calls, ongoing needs assessment about, food needs, formula, diapers, all this sort of instrumental support that comes up and that changes over 10 days potentially. And then we delivered food, cleaning supplies, things that people would need. And then also at the end of it, linked people to primary care and insurance if they weren't already linked. And the goal is that you sort of leave the model sort of feeling better and connected to to primary care and community resources. So that is the model. The model is really led and delivered by our community team. And this, of course, is just built on existing community health worker led models of care that have existed before COVID. And so I know many of you all know it, but just to highlight, the community health workers shared language, ethnicity, community, or life experiences with the client, and wealth of data to support this and their role in engagement and retention and care in a number of health domains such as diabetes, asthma, and HIV, and certainly as we're seeing it, I think, in COVID. And there's a lot of momentum now, and I'm sort of privileged to also work with some folks from IGHS, including Mike Reed, on thinking about community health worker-led models in contact tracing and sort of really a unified CICT contact tracing and community health, community wellness teams sort of models. But there's a lot of movement around that, and I think really central to addressing the health disparities that we're seeing. And I just want to point out that the community wellness team, the people that are doing the calls, delivering the food, they're all sort of community members with clinician backup. So this is just an example from April, sort of just illustrating our care cascade for the community wellness team. And you can see from our 83 people who tested positive, we reached 80 people. And then 60 of those people really needed additional support to maintain isolation and quarantine. And we're connected to the community health worker, community wellness team model. So of those 60, 56 connected with the community health worker model, community wellness team. And then the majority of people just stayed with this program the entire time of isolation. So 54 of 56 people received services their entire time. And it was, I think, a humbling experience just to see sort of how the needs and the interactions with the community health worker team changed over time. You know, we certainly just provide one anecdote of an older gentleman who in his, I think, 70s or 80s, who tested positive. And initially when our team reached out to him, he didn't want isolation and quarantine, hotel referral. And then we couldn't be like checked in a little bit regularly. And then over time, we discovered that he was so nervous about spreading COVID to his family. He was staying in an abandoned building. And then we were able to, with trust, get him to an isolation quarantine hotel. And so I think this community model really helps address sort of, in a longitudinal method, addresses some of the trust barriers. Okay, so just quickly, outcomes from the community health worker, community wellness team. So I wanted to just highlight a few features. So over 55% of folks did not have health insurance. So when these people are receiving positive results, they don't have, you know, their primary care doctor who's checking in on them or someone to call easily. So I think that need to have longitudinal support is great, and then also the linkage need. The majority, of course, had household income less than 50,000, and 19% disclosed more household contacts after engaging in the community wellness team. So that trust sort of allowed them to be able to kind of feel comfortable disclosing that instead of 4 people, they actually had 15 people in the household, for example. And then we were able to reach over 230 household members, as we know that this is not just about the one person who's positive, but about the whole household, because the whole household has to remain in quarantine. And then I think the feedback certainly was that the Spanish-speaking staff was a critical piece, as expected. I think at that time there were many there were a few, I think, identified unmet needs in that program. And I think social protections was a critical component. At that time, we did not have the Right to Recover Act in San Francisco. And I think just the need for income supplementation and job security during isolation and quarantine was sort of at the top of people's needs, and one that we were not able to fully address at that time. And then I think we still need to continue to work on sort of lower barrier linkage to healthcare. And then lastly, I think, and I think things have changed since this study, but I think continuing to really think about ways to easily get household contacts tested, and thinking about ways to bring testing a little bit closer, instead of having to go down to the Embarcadero or et cetera. So those were some of our kind of findings or observations. So I think just in conclusion, low barrier community-led testing has a greater reach than some of the traditional approaches, and certainly merits expansion. And I think since the April study has been expanded, social supports and community-led wraparound services can reduce barriers to testing and end adherence to isolation and quarantine. And I think the Unidos and Salud study really highlights the importance of community academic partnerships in generating data to drive policy programming and science. And I'll just close with, why we do this is really data to drive policy and solutions, and really address some of the disparities we're seeing. And so this is just highlighting some of the ways that data has really influenced changes. And so I'll put on the left, this is a picture of testing at the community-based testing at the Latino Task Force Food Hub. This is a partnership with DPH and the Latino Task Force every Thursday. So they have now every Thursday low barrier testing site. There was also expansion of, at that time, essential workers, asymptomatic testing of essential workers. After the study, we saw the legislation for social supports with the Right to Recover Act. And then there have been a number of community-based testing sites and campaigns in other communities, and sort of adaptations to this model to make it fit other communities. And this is just a picture of the second community campaign, United in Health, in Bayview, and some of the fantastic community leaders there. And that, I'll just go ahead and end there, and just a large thank you to the many people that have been involved in these efforts, and especially the Latino Task Force, and you can see pictures on the side, who have just been central and instrumental to making this happen, and it's an honor to work with them. So I will close there.
Thank you so much, Dr. Marquez, Dr. Chamie, for this fascinating presentation. My colleague Colin Boyle will help me in moderating some of the Q&A, but I cannot wait to ask you a couple. If I may, Dr. Marquez, I find this Testtocare model fascinating. What about scalability and sustainability? Who's paying the price tag for this, and can we bring it to another scale?
That's a great question, and I think there's two kind of comments on that. I think it is overall a relatively low cost intervention, at least on the Right to Recover is a very important component. That's a little bit higher cost, but the community care model is very low cost. And our for the 83 positives, we had 3 community health workers working, and I think it's in delivering food and connecting with people. And I think the sort of larger, while it's just funding for 3 folks, it also has so many larger implications, because we've been tracking this a little bit more with our BART study, and we have more data on this later, but I think the people who are participating in the program really probably are able to adhere to isolation and quarantine better. That we don't have definitive data on this, and so that there is so much more, there's a lot of benefit to that. And I think there is a lot of effort on the DPH side now to really scale this and provide more funding for community teams to be able to do this. And so there's a lot of movement on that front. I think it's really critical. And I think it's, while there is a little more cost, I think you get a lot of benefit out of it. And I think it's not who should be funding, but I think to be able to address this epidemic and to curb transmission, we need to do it. It's an essential piece. To really, especially when we're really trying to reduce disparities. I think without this, it's going to be very hard to do that.
Thank you. Let me turn the floor to Colin Boyle, and perhaps if I still may ask Gabriel about the success of San Francisco as a model. It has been said that San Francisco is a metropolitan area with the lowest mortality rate by COVID. And if that is true, what is the reason? What are the reasons behind success, and whether this is something that will continue? Is there a risk of fatigue and complacency? So, Gabriel, I don't know if you have any comments.
are great questions. And the first, I'll say that it's often, as I think the audience knows, but challenging to establish clear cause and effect. However, there are clearly things that San Francisco, I would say, did well and did right as a city. First, we were the first metropolitan area to have a shelter in place. And I think that quick action, there's fairly clear evidence that the longer the delay in taking action in terms of public health measures resulted in higher caseloads. Those higher caseloads in turn can overwhelm hospitals and healthcare workers and our capacity to care for people. As we saw in some very unfortunate, as people remember, but early on in both New York City and Italy. So the higher the number of cases, I think you often will see a correlation with a higher mortality as hospitals and care services become overwhelmed. So sheltering in place was one factor. I think also as a city, my understanding, and I don't have data in front of me this here, but that masking has been quite high. And I know Monica Gandhi, for example, will be talking in several weeks on this same venue about the role of masking and how that may limit, even if people become infected, the amount, or if you will, the dose of virus to which a person is exposed, which seems to, based on some available evidence, is hypothesized to reduce the severity of infection. So those with heavily virus exposures getting more sick than those who are not. But there's certainly other factors at play, including population density, age of the population. I think there's many things we can point to that the city has done quite well. I will just say a brief, also a nod to the early access to treatment trials, the remdesivir studies, which San Francisco was a site for some of these clinical trials as well, which was wonderful. So those are some things to consider. In terms of your question about complacency and fatigue, I think everybody is fatigued by the pandemic, but that hopefully San Francisco's and the Bay Area's success in many ways, not that I think we have areas to work on, but should be kind of an impetus to keep the energy up and hopefully to continue to innovate and figure out ways to overcome, there's things we don't know that we need to learn through research and through ongoing implementation. And then there's misinformation. And I think being clear and consistent in messaging and trying to overcome rumors or misinformation and keeping people energized is important. And I think there's also been a lot of effort to have people communicating and socializing in new ways. I just say that as a parent who has 2 kids in distance learning and trying to get creative in terms of how to push back against some of the challenges. It's been particularly hard, I think, for everyone with the wildfire smoke and other things too. But I don't think we can be complacent for those of us who are observing a lot of the inequities we're seeing in San Francisco. And I think if anything, we hope that some of these data should galvanize people to get involved. And I'd say one major area is really trying to match our low barrier testing services, increasing those in places that are highest need, rather than sort of a general approach of kind of testing around the city, but bringing it to people who are most in need.
Thank you.
Thanks for that wonderful presentation. There are a couple of questions that were posed to the Q&A box about some specifics in the studies and your next steps. Before turning to those, I have a bit of a meta question for you. Here you talk about low barrier access to testing and linking testing to care and community health workers. I was struck and remembered that you've both been involved with the SEARCH program. And one of the interesting things about global health is the degree to which innovations started abroad often come back here to the benefit of local communities. I'm just wondering if you guys could comment a bit about how your global health work informed the way you approached this.
I can start if you'd like, Carina. Or, it informed it tremendously. I think both domestically, the HIV response and working with communities to address the HIV epidemic, which is something in which San Francisco has a long record of, but also the international AIDS response and how communities at the forefront of the response has been really a key to the HIV response globally, has informed us. And then specifically within SEARCH, as co-investigators on SEARCH, for those who may not have heard of it, it's the Sustainable East Africa Research and Community Health Project. This is a study led by Diane Havlier, Moses Kamya, Maya Peterson is the PIs, but a large group of investigators around the world looking at broad-scale HIV testing and treatment was the first part of the search study in 32 communities in Kenya and Uganda. Just as I won't go into huge amounts of depth on it, but I think meeting with communities, figuring out what the needs of people testing were from that vantage point of service provision was something that we learned in search that was, I think, informed very much how we thought about, okay, how do we bring testing to communities? And also this, I'd say the population viewpoint of this assumption that like a health clinical setting has a clear idea of exactly what's going on in the community. I think we know that not always to be true. So getting out in communities, meeting with community members, and bringing testing out of health facilities is something that I'll say I learned a lot about in search. We did large-scale community health campaigns, and they weren't always just focused on HIV testing. So often what we did is what we called it multi-disease health fairs, but we had a broad array of services, whether it was vitamin A for children, testing for high blood pressure or diabetes. And I'd say why that was important is over time, people might fatigue of, you need an HIV test, you need an HIV test. That's often a very sort of funder program driven approach. Whereas from a community perspective, they might say, I have a lot of, I'm worried about my health. How is my health? And that informed how we delivered search and led to us testing after 3 years, about 90% of the residents and over about 1/3 of a million people in the settings where we were working. So it led to really high coverage and a lot of retesting too. So there wasn't as much fatigue because of the freshness of services offered, again, from that viewpoint of what is starting point of what are the community's needs. And on the service delivery side, I know that search also, we really put a lot of effort, the whole team, into how care was delivered, making services streamlined, easy to access, and not putting the onus on people. You meet them where they are. You don't say, our services are here. If you can make it great, if not, too bad. So I think those are some main messages of search. Carina, I don't know if you'd like to add anything, but I would just say it also highlights, we call it global health, but it's really, we're part of a global community and there's a dual exchange of information. We learn things one place or another. And I think best implementation science efforts are when there's really a back and forth and it leads to new ideas and movement forward.
Yeah, I'll just add like two comments. I think this, certainly builds off a lot of the community health approaches that we've had, which Gabe talked about. And then I just was thinking of just the idea about community spaces and the low barrier testing for other things or low barrier services. And one of the things we did yesterday at the 16th and BART station is we also, on the other plaza, had flu shots that were offered by Walgreens, and the demand was fantastic, and it was exciting to see. And there's a lot of people who may not have a healthcare provider that they can walk into and get their flu shot, and sort of thinking about sort of the location and how it's delivered and how to be able to reach people who may not be connected to care or accessing other services is difficult. So COVID is one service of many, or COVID testing is one service of many, and I think the low barrier strategy works for a lot of things.
Colin, you're on mute.
Sorry, thank you for those comments. I appreciate that very much. There were a couple of questions about some of the specifics in the study that I think would be helpful to clarify. One was on the mission study and the dive into the household transmission. I don't know if you had enough of a sample size to be able to determine whether there were any differences between large crowded households and smaller crowded households, or any cuts there that would be significant enough to draw conclusions from.
Yeah, it's a good question. I would say that the inequities that drive differential COVID-19 rates or SARS-CoV-2 infection rates, they are, I don't use the right term, but highly correlated, so that low-income households in San Francisco, with the skyrocketing housing prices over the past several decades, have led to increasing amounts of people in multi-family homes, multi-generational homes, and multiple people, perhaps sharing a residence, whereas the luxury of having, say, 2 people in a large multi-bedroom home is for really high-income people. So we did see a trend towards, or we saw a relationship between greater population density or housing density and COVID rates, and it really, again, correlated with a lot of these other things that we saw in terms of income in the study. And in fact, if we, within Latinx individuals, which is a range of economic outcomes, definitely lower income Latinx, that is where we saw the bulk of infections. And yeah, so the question about housing is a good one. I did see also the question about droplet versus aerosol transmission, which we can't really comment on in the study. It's a good question, but remember at the time we were doing this study, masking was relatively new. Household transmission was likely, had been ongoing prior to people even considering wearing masks in homes. I know at that point, many of us there wasn't clarity on masking even in the hospital beyond a regular mask, whether or not you need an N95 or et cetera. So.
Great. One other question about the test protocol, and did you have a way of determining whether there were repeat testers, people who might be coming back in after a negative just to be sure, or was there a way to check that in the study?
Yes, I think at the time, Gabe, I can't remember if in the April we had that as a question, but certainly in the 24th admission study, that was one of the questions that we asked before, if you've ever tested before. I don't have the data right in front of me, but I think 70% of people it was the first time testing, but 30% were repeat testers. And I think that want regular testing, and that question actually came up yesterday, where people were like, well, I just was tested 2 weeks ago, should I retest? And sort of, I think that there is a lot of importance in terms of guidelines and messaging about retesting that we actually need. I think yesterday this also sort of brought that to the forefront, that certainly, especially if you're an essential worker, I think retesting is very important, and there's little guidelines on how frequently one should retest, and so.
I totally agree. Yeah, we didn't discourage people who had ever tested for COVID before. The number were obviously fewer in April than now. We didn't discourage people from coming if they had tested before, but the numbers who had previously been diagnosed with COVID in our study were quite low. I think the total N out of more than 4,000 tested was 12, and 6 of those were PCR positive. All with quite low levels of virus, meaning that they were probably slight persistent shedders with non-viable, non-transmissible virus.
Mm-hmm.
Okay, I know we're running short on time here, so one last question, which is really about the potential associated with these kind of community-friendly, low barrier access hubs. And I'm just wondering if there are thoughts about extending it to maybe families as a population. It feels like at a BART station, you're going to get commuters to work, but maybe not kids. And I'm just wondering, aside from the kids who live in that neighborhood, any thoughts about how to do that, or whether there's any energy behind extending this model to a broader demographic group?
Mm-hmm.
I think the quick answer is yes. I will I'll just briefly say in the April, and I'll let Carina handle the other half of it, but we did have an attempt a kid-friendly day, and it went fairly well. But we did meet parents who said, for example, while I'm getting tested myself, depending how it goes, I might bring my kid in a couple of days. This was during shelter in place, and I think there was some unease about swabbing a kid or bringing them to a testing site. However, I think it's a necessity, and really, again, meeting people where they are and making it as convenient as possible. There's no reason, in my opinion, families shouldn't or couldn't test together. I think it's something one could deliver.
Mm-hmm. Yeah, and I think these questions will start coming up also more as schools open and there's more need for testing. I think a lot of testing sites right now do not test children under 12. And so I have heard that finding testing for younger children has been a little bit challenging. And I think people are working on sort of ways to expand that. But I think that there is a need. And then also, especially for kids who are household contacts, sort of trying to figure out where, sometimes there's barriers on getting them tested too. So I think it depends on the site. There's some transport hubs like 24th and Mission there's already a lot of, families that live nearby and walk by, but other transport hubs like, I don't know, Balboa Park that may not be as family friendly, for example, I don't know. But so I think thinking about the location does matter for families.
Great, well, thank you both. Fantastic presentations.
Thank you so much. We unfortunately have run out of time. I want to thank our speakers, Dr. Gabriel Chamie and Dr. Carina Marquez, for a really fabulous presentation. Look forward to have all of you in 2 weeks' time for our next webinar. And please don't forget to get your flu shot. Thank you and see you soon. Bye.
Thank you.